ischemic stroke. And you know, ischemic stroke, there are many causes for ischemic stroke, including the arteriosclerosis, small vessel disease, cardiac emboli, vasculitis, arterial dissection, systemic lupus, sickle cell, and many of the coagulopathies that can result in vascular occlusion, and this will proceed to the formation of an infarction in the brain. The signs and symptoms of ischemic stroke are numerous, starting from the sensory defect and visual field defect, diplopia, dysarthria, ataxia, aphasia, and even seizures in some of the cases. The stroke is usually of hypodense appearance in the CT scan. And we have the three types of stroke: the acute one, the subacute, and the chronic. All the acute, subacute, and the chronic appear in the CT scan as hypodense area related to a certain vascular territory, meaning that the anterior part of the brain belongs to the anterior cerebrum. The middle part of the brain belongs to the middle cerebrum, and the occipital lobe as well as the cerebellum belongs to the posterior circulation. Then you know that infarction is not a space-occupying region, meaning that you don't expect a significant mass effect of an infarcted area on the adjacent ventricle. And it passes into three stages. It has a vascular territory, and in many times it has a cortical distribution. Then acute infarction is surrounded by edema. Edema is black in the CT. Infarction is black in the CT. Then you cannot discriminate edema from the infarction, but you know that this infarction is surrounded by edema because of the mass effect on the ventricle. If you see the infarction and the ventricle is compressed, then you know that this infarction is surrounded by edema and it is acute. But if you see an infarction and you see that the ventricle adjacent to the infarction is dilated, you know that this infarction is old, and there is liquefaction, and there is loss of volume, and the ventricle is dilated to compensate for the loss of volume caused by liquefaction of the infarction. Then this is a chronic infarction, and this is acute infarction. And what about the subacute infarction? The subacute infarction is a hypodense area that does not affect the ventricle. It does not compress and not dilate the ventricle. If you see an infarction like this, you know that the edema has disappeared, but the infarction is not yet liquefied. This meaning that this infarction is in the subacute phase. And if I asked you about the phase of this infarction, you will say that this is acute infarction because of the significant mass effect on the adjacent ventricle. Then there are many signs of acute stroke. Many times you have seen in clinical practice someone who developed acute stroke, and he is rapidly transferred to the CT unit, and the CT scan was absolutely normal. That's because the ischemic brain is not yet black. It takes some time to appear black in the CT scan. But at that time, you have many other signs that can tell you that there is an stroke. One of these signs is known as the hyperdense vessel sign. The hyperdense vessel sign means that there is clotted blood in the middle cerebrum, which is the most common territory for ischemic strokes. If you see that the middle cerebral artery is hyperdense, you know that the artery is thrombosed. and you look carefully to see the infarcted area, you may see it or you may not. At that time, you call this hyperdense vessel sign, and you call this infarcted area a hyperacute infarction. A hyperacute infarction that is ischemic brain tissue that is not yet seen in the CT scan. Another sign for the hyperacute infarction is known as the basal ganglia fogging sign. If you look here, you will see the head of the caudate nucleus, you will see the thalamus, and you will see the lentiform. If you look to the opposite side, you cannot see these structures because the ischemic brain tissue has masked the anatomic details. And at that time, this sign is known as basal ganglia fogging sign, and you expect the infarction to appear after that. And here another example. Look here, this is the head of the caudate, lentiform, and thalamus. You see it clearly. But on the opposite side, you cannot see these structures. After some time, you got the appearance of the infarction. Then hyperacute infarction is not seen in the CT scan, but can be predicted by the signs as I mentioned. Number one, the hyperdense vessel sign. Number two, the basal ganglia fogging sign. Then if I asked you about which is the possible site for an infarction to develop, right or left? Right. Very good. This is right. And this is follow up after 24 hours, and you got to the hypodense area at the site of what looks like the basal ganglia fogging sign. And sometimes when you transfer the patient to the CT unit and you got an almost normal CT scan, then you change the window of the image. This is known as a stroke window, And this window may help you to predict the site of the infarction, which is right, yes. And here you see the basal ganglia, but here you see masking or fogging of the basal ganglia, and the infarction has developed 18 hours after the first examination. Many times, if you follow the infarction, you got hyperacute infarction, which is not actually seen. Then the infarction developed with some mass effect. Then after that, the mass effect is increased, and later on, there is loss of volume and dilatation of the ipsilateral ventricle. This is hyperacute, this is acute, and this is chronic infarction. Then the territories of the infarction, as I have mentioned. The anterior part is for the anterior cerebral artery. Most of the hemisphere belongs to the middle cerebral artery, and the posterior part belongs to the posterior cerebral artery. Then there is a scoring system for the infarction to be treated either by interventional radiology or by injection, systemic injection of thrombolytic agent. This scoring system is known as aspects score. The aspects score gives a number or a unit for each part of the brain. And you remember this level is the level of the basal ganglia, where you can see the third ventricle. And on the surface of the brain, you have 3 zones. Above this level, you have another 3 zones. For each zone of these, you give number 1. Then you have 3 and another 3. Then you give a number for the head of the caudate, another number for the internal capsule, a number for the lentiform nucleus, and another number for the insula. Then if you sum up these numbers, you got a score of 10. any area affected by the infarction, -1 from the score. -1 from the score. Meaning that the normal brain score is 10. The normal brain, the score is 10. If this is the site of the infarction only, then the score is 9. If these 3 areas are affected, then the score is 7, and so on. Then if you look here, and you got 3 areas here, another 3 areas here, and the insula is affected, then the score is three. Yes, the score is 3. And these are the 3 which are spared: the head of the caudate nucleus, the lentiform, and the internal capsule. Then what is the value of this scoring system? It decides if the patient is to be injected by systemic thrombolytic agent or not. All the criteria supports the idea that if the score is below 7, above 7, if 3 areas only are affected, then you may give the patient by an intravenous thrombolytic agent. But if more than 3 areas are affected, systemic thrombolytic material is contraindicated, because this will result in bleeding in other sites. And many times when they give the patient the systemic thrombolytic agent, he bleeds either in the brain or any site or any other site in the body. And this is the value of this aspect score, and this aspect score is also given for the posterior fossa. A number for each cerebral hemisphere, and a number for each thalamus, and a number for each occipital lobe, and 2 numbers for the brainstem. One for the medulla, and another one for the midbrain. And also 10 points, and only 3 sites are affected, you are able to give thrombolytic material. Then we have agreed that if the patient had a stroke, then you should pass first by the CT scan. You should have initially a CT scan. And you will see one of 3 possibilities. Number 1, you detect an infarction. Number 2, you see a hemorrhage. Number 3, you see nothing. Number 1 and 2 are treated conservatively. And number 3 is transferred for MRI. Whenever you cannot see the stroke, you go direct for MRI. And you have, previously they were 3 hours, but now they are 6 hours. You have 6 hours to save the brain. Then, if you see nothing in the CT brain, then you go for MRI. And this MRI should include diffusion weighted images and should include MR angiography, both. Then at that time, this is the normal brain. By diffusion images, you see the infarcted area. On MR angiography, you see the occluded vessel. Then you transfer the patient directly to the interventional unit. And immediately you go by catheter to the artery and inject selectively a thrombolytic agent, or recently you remove the thrombus itself, then the patient and the next day is going out the hospital walking on his feet. Then اللي بيحصل الحقيقة في حزام البؤس غير كده خالص. يعني نمرة 1 بيكون المريض عنده اسبكت سكور منخفض جدا وبيحقنوه انترافينوس ثرومبوليتيك ايجنت، وده بيجيب له نزيف كتير جدا. الجماعه بتوع النيورو سيرجري يعني بيقولوا لي قد ايه كم الحالات اللي بيطلع من الجماعه بتوع الستروك يونت ليهم فوق عنده هيمرج علشان خاطر يفضيه. الحاجه الثانيه اللي هي قيمه الوقت، لانك انت في المنطقه بتاعتنا ديت ال6 ساعات كلهم بيروحوا في الاشارات. يعني عقبال ما تنقل المريض من مكان اللي حصل له فيه ستروك الى الحته اللي هو هيتعالج فيها بيكون خلاص الوقت خلص في الاشارات والمرور والكلام ده كله. والحته اللي احنا عايشين فيها ما تعرفش تطير طياره في الجو، يعني عشان بس تبقى انت فاهم، لان الستروك سنترز العالميه كلها عندها طيارات. لما يكون في واحد في حته وانت عاوز تنقله بسرعه والمرور والكلام ده كله بتبعت تجيبه بالطياره، وبيكون في المستشفى فيه بتاع مهبط طيارات. لكن انت عشان تطير نمله في الجو عندنا في البلاد بتاعتنا لازم تاخد 7000 تصريح، ومش هتاخدهم، يعني مهما اوتيت من قوه مش هيحصل انك انت تطير اي حاجه في الجو. وبالتالي دي قيمه اللي انا بقول لك عليه. الطب هو الامرجنسي. لما يكون في واحد عنده ستروك وانت خرجته ماشي تاني يوم الصبح على رجليه من المستشفى يبقى انت انجزت. لكن انت عندك واحد عنده ستروك عملنا له سي تي برين طلع نورمال، ما تخافش احنا نعمل لك سي تي بكره الجلطه هتبان على طول. طب وبالجلطه بانت يعني ايه الريفرسبل برين دامج؟ يعني انتهى الموضوع خلاص، على كده خلصت الحكايه. وده حقيقه هو اللي كان بيحصل وما زال بيحصل في بعض الاماكن. تعمل سي تي برين يطلع نورمال، يقول اعمل له سي تي برين فولو اب بعد 24 ساعه، الحمد لله ظهرت الجلطه، انت اتشليت مدى الحياه والامور مشيت على كده. المهم then one of the essential findings similar to the hyperdense vessel sign is hyperdensity in one of the middle cerebral branches. And this is also very important. If you see one of the Sylvian fissures is showing a hyperdensity, meaning that it is thrombosed, then you do not see the infarction itself. And you go for MRI, and you should include diffusion weighted images, and you see the infarcted area. Then you go for intervention. This is an example. In the brain CT, you see nothing. An MRI diffusion, you see the full extent of the infarcted area. After thrombolytic intervention, and you got significant regression of the ischemic brain tissue. And this is the goal of treatment, is to save the patient from permanent irreversible damage. And if you see an infarcted area and you do not see a mass effect, and this is subacute infarction. And subacute infarction means that this is irreversible damage of the brain and is not an indication for any intervention. After some time, the infarction will liquefy, and you got very evident loss of volume, and the ventricle on the same side of the infarction will dilate to compensate for the loss of volume of this chronic infarction. Then if you look for MRI and you want to know if this infarction is acute, subacute, or chronic, you look for the ventricle on the side of the infarction. If the ventricle is compressed, this is acute. If it is dilated, this is chronic. If it is not changed compared to the opposite one, and this is subacute. Many times after the development of the infarction, and the infarction is chronic and is liquefied, then the ventricle is dilated, and to the extent that the fluid in the area of the infarction is now communicating with the fluid inside the ventricle, and this is known as borencephaly. Borencephaly means that an area of damaged brain tissue, dead brain tissue, that is communicating with the ventricular lumen. This is known as borencephaly. What happens if you inject the infarction with contrast material? An infarcted area, if you thought that this may be a neoplasm, you may inject contrast material. If you inject contrast material for an infarction, it will show the classic pattern of enhancement, which is known as gyral enhancement, previously known as luxury perfusion. And this is an old obsolete term. Luxury perfusion is no more used, but the right term is gyral pattern of enhancement, which is characteristic of the infarction. Then what happens if you have an MR spectroscopy for an infarcted area? You do not get significant changes in the metabolites, original metabolites. Some decrease in the N-acetyl aspartate, some increase in the choline, and evident peak of lipid and lactate, yes. Many times, if the infarction is long-lasting, it will develop internal calcification, and this is known as dystrophic calcification. And this calcium should not be mistaken for hemorrhage. Should not be mistaken for hemorrhage, because the hemorrhagic infarction is an acute one. It compresses the ventricle. But this infarction is very old and has dilated the ventricle, and then this represents dystrophic calcification in an old infarction. Many times you have what's known as a hemorrhagic stroke, an infarction with internal hemorrhage. And the infarction with internal hemorrhage has two types. Type 1 is a big infarcted area with minute petechial hemorrhage inside. Type 2 is an infarction with a big hematoma inside, which may be mistaken for hemorrhage surrounded by edema. Then if you look here and you see an infarcted area with subtle hyperdensity inside, how can you know that this is blood? This is acute blood. Then if you have an MRI T1, it will appear intermediate signal, yes. In the T2, dark signal. And in the gradient image or susceptibility weighted image, you see the hemorrhage as a dark area. Then what are the causes of hemorrhagic stroke? Number 1, venous thrombosis. Number 2, arterial embolism. Number 3, the medications after thrombolysis, whether it is by anticoagulant or injected through the vessel by catheter. If you look here and you see an infarcted area with mass effect on the ventricle, meaning that it is acute. And you see some hemorrhagic foci within the infarcted area, meaning that it is a hemorrhagic infarction. If the venous side is occluded and the blood is coming through the arterial side, then the capillary blood pressure will rise, then many of the capillaries will rupture, produce hemorrhagic infarction. And sometimes if you give thrombolytic material and the thrombosed vessels, the wall is very diseased, is very weak, then after the blood is coming back to the flow, then it will rupture the diseased vessel wall. And this is another example. You see an infarcted area with some hemorrhagic foci inside. And this is another infarcted area, and you got some hemorrhage inside, and this hemorrhage has an access into the ventricular lumen. And this is a hemorrhagic infarction that developed after anticoagulant therapy. Sometimes you have to follow the infarction by CT guarding against the development of hemorrhage inside the infarcted area, as you can see in this example. And this is another example of infarction that has developed hemorrhage because of the thrombolytic agent. The thrombolytic agent will try to dissolve the thrombus and to maintain the blood flow again to the area, to the affected area, and this blood flow will result in rupture of some of the weak vessels, resulting in this hemorrhage. Then in the MRI, the acute blood will appear of intermediate signal in the T1, dark signal in the FLAIR and the T2 weighted images, very dark signal in the gradient image. Also, I said that if you see that the dural sinus is bright in the T1, bright in the T2, meaning that it is thrombosed. And this thrombus is in the subacute phase, which is late subacute blood, extracellular methemoglobin. Dural sinus thrombosis, and similar to any venous thrombosis all over the body, and there are many causes, and 3 of these causes are related to the pregnancy. The pregnancy itself, and the puerperium, and the contraceptive pills. All these 3 factors can predispose to venous thrombosis, including others like the trauma, brain tumors, surgery, hematologic disorders, and so on. What are the symptoms of dural sinus thrombosis? There are 2 main symptoms. And even you can diagnose the dural sinus thrombosis in a normal imaging of the brain, like CT or MRI, from only the symptoms. The neurosurgeon said that if the patient had severe headache and seizures, and you do not see any lesion in the brain tissue by CT and by MRI, think of acute dural sinus thrombosis. And to see the acute dural sinus thrombosis, you have one of 2 ways. Either you inject the patient with contrast and do CT venography. I prefer to do MR venography, which needs no contrast injection and is very accurate compared to the CT. Then, how can you diagnose dural sinus thrombosis from MRI if it is not acute? By the detection of clotted blood in the sinus. You see, the sinus is bright in the T1 and bright in the T2, meaning that it contains subacute blood. If you inject the patient with contrast, the sinus will not enhance because it is obstructed by the thrombus. But if you have the MR venogram, compare the normal appearance by the abnormal appearance. The normal, you see the internal jugular vein, the sigmoid sinus, the transverse sinus, and the superior sagittal sinus. But here, you see the sinuses on the right side, and you do not see the sinuses on the left side. The transverse sinus is thrombosed, the confluence of the sinuses is thrombosed, the sigmoid and the internal jugular vein. One of the most important issues in this particular area is the thrombosis of the deep system, the thrombosis of the internal cerebral veins. You remember that internal cerebral veins are located in the quadrigeminal cistern. 4 structures are located in the quadrigeminal cistern: the vein of Galen, the internal cerebral veins, and the pineal body. If the internal cerebral veins are thrombosed, they appear hyperdense in the CT scan. And you see here, hyperdense internal cerebral veins in the CT scan. And the effect is usually on the thalamus. Then you got infarction in the left thalamus and another infarction in the right thalamus. These infarctions are black in the T1 and bright in the T2 and the FLAIR. If you have an MR venogram, it's usually difficult to see the internal cerebral veins, but you can see the veins very well in the CT scan, especially if they are thrombosed, as you can see in this particular case. Lacunar infarction is an infarction that is less than 1 centimeter by definition. A small infarction that is less than 1 centimeter. This infarction does not produce any mass effect on the surrounding structures because it has no significant size and no perifocal brain edema. And these are the common sites: the basal ganglia, the thalamus, internal capsule, white matter. Many times, especially in old patients or those who are hypertensive or diabetics, you get what is known as subcortical arteriosclerotic encephalopathy, meaning that ischemic white matter changes, meaning that the white matter is more dark in the CT images compared to its normal appearance on the CT. The white matter is a little bit dark in the normal conditions, but it's very dark if it is ischemic. Then, if you want to see what happens in the white matter, and you may have MRI. In an MRI, you see the white matter is black in the T1, bright in the T2, bright in the flare, with many infarctions in the white matter. If you want to know if these infarctions are acute or chronic, and you should have the diffusion weighted images. Then you see here in the flare multiple infarctions in the white matter. In the diffusion weighted images, only this one is the acute one, which is bright in the diffusion and dark in the ADC. The rest of the infarcted areas are old because they do not produce diffusion restriction. This patient with systemic lupus erythematosus, and you got many ischemic changes in the white matter. And in the diffusion weighted images, this is the only acute infarction, which is located here, showing diffusion restriction, bright in the T1 and very dark bright in the diffusion weighted image and dark in the ADC. Then this is the value of the gradient image or the susceptibility weighted images. Many times, many patients with subcortical arteriosclerotic encephalopathy have diseased vessels, and these diseased vessels may bleed, and this bleeding is known as microbleeds. Microbleeds. You cannot see these microbleeds except by the gradient or the susceptibility weighted image. And the detection of microbleeds in patients with subcortical arteriosclerotic encephalopathy is very important because these will precipitate to more bleeding with the initiation of treatment. And you should mention very clearly in the report if the patient with subcortical arteriosclerotic encephalopathy has microbleeds or not. And this cannot be evaluated unless you have the gradient or the susceptibility weighted image. And you see here, these are two flare images, and you got many ischemic lesions in the white matter. But it's only the susceptibility weighted image or the gradient weighted image which can clearly demonstrate the presence of microbleeds. Another example, you see ischemic white matter changes. If an old patient with hypertension or diabetes or both is examined by MRI and you detected many ischemic foci in the white matter. Number one, you should look for the diffusion weighted images to spot the acute insult. Number two, you should look for the gradient image or the susceptibility weighted image to see if there is associated microbleeds or not. This is very important, very important. And the differentiation between microbleeds and many other lesions is well known, of course, in the literature, including calcium, including the blood in the blood vessels, which is clearly seen in the susceptibility weighted image, including the cavernoma, which I will discuss in the coming lectures, including the hemorrhagic metastases. And of course, the hemorrhagic metastases are diagnosed by the presence of significant brain edema around the metastasis and the clinical history of primary malignancy. Diffuse axonal injury, I will also discuss in the pediatric images, and this is easy to be discriminated because of the history of significant trauma and the presence of skull fractures and the state of the patient itself. Patients with diffuse axonal injury are almost comatose. Then we came to the disease which is known as the breast or the posterior reversible encephalopathy syndrome. This breast was supposed to be to result from sudden increase of the blood pressure, resulting in vasospasm of the circle of Willis, and this vasospasm will result in brain edema first, then ischemic changes after that. They said that these lesions are usually posterior because the posterior circulation is more weak than the anterior circulation. So if the patient has developed acute increase in the blood pressure, the vessels will go into a spasm, and this spasm will result in edema, and this edema is usually bilateral and symmetric, and is located in the posterior circulation, in the cerebellum and the occipital lobes. The patient develops seizures. This is the main presenting symptom is seizures. Then you perform CT or MRI, and you got edematous or ischemic lesions in the posterior part of the brain. Then, if you have a diffusion weighted image, and you see that there is diffusion restriction, meaning that the lesions are ischemic, not edematous. If you got diffusion free, meaning that the lesions are edematous and not ischemic. What is the value of this? You know, if the brain is edematous and you succeeded in lowering the blood pressure, then the edema will improve and the lesions will regress. And that's why the lesion is known as posterior reversible encephalopathy. And many times you cannot lower the blood pressure in a reasonable way to overcome this edema. Then the patient will go into ischemia. And this ischemic changes will never reverse. It will persist, and you got at that time diffusion restriction. Then the new literature says that the lesions are not usually reversible. The lesions are not usually reversible, meaning that they may improve, but they will not disappear. They may improve, but will not disappear. Then if you see lesions like this, and you do not see diffusion restriction, you know that these are edematous changes. And the edematous brain, if you do not improve the circulation, will go into ischemia and diffusion restriction. The causes are, according to the literature, sudden increase in the blood pressure. And these changes, acute glomerulonephritis, infection, autoimmune diseases, cancer chemotherapy, preeclampsia and eclampsia, hemolytic uremic syndrome, thrombotic, thrombocytopenic purpura, and organ transplantation. These are the possible causes for this appearance. And the CT scan, you got hypodense areas, bilateral, symmetric, in the posterior areas of the brain. An MRI, you got low signal in the T1, high signal in the T2, and the flare. If you do not see diffusion restriction, this is edematous changes. If you see, this is ischemic changes. In both conditions, if you inject a contrast material, these lesions will not enhance. And this is an example with the follow-up of the lesions. Here you see some changes, all bilateral symmetric in the posterior circulation with no diffusion restriction and no contrast enhancement. And this is the follow-up of the lesions. And you see also there is no contrast enhancement nor diffusion restriction. And this is another example. You see the lesions, the start and the follow-up of the lesions, they have regressed, but residual lesions are still seen. And this is the condition we see in the clinical practice. We do not usually see full regression of the lesion. We see only partial regression of the lesion. Yes,